Welcome, everyone. Today, we're here to learn more about an important topic when breast cancer runs in the family. My name is Lindsay Anderson, and I am the Hematology and Oncology Service Line Manager. Thank you so much for being here today. We're very excited to have you. Whether you're seeking to enhance your knowledge, support a loved one, or be proactive about your health, this is a webinar for you. Your participation and engagement are welcomed. We have a poll on the screen that we would love for you to fill out to just share a little bit about why you're here today. There will be a question and answer segment at the end of the presentation. This is your opportunity to ask questions. The rest of the group will not be able to see your questions. They're submitted to our panel, so please don't be shy. Our panel is here to help, and they're excited to hear from you. Today's panel includes two exceptional Sturdy Health physicians. Dr. Asma Latif is a board-certified medical oncologist and hematologist, and is the director of breast oncology at Sturdy Health. She received her Doctor of Medicine from the University of Kansas School of Medicine. Her clinical practice is dedicated to caring for people with various forms of cancer while specializing in breast gynecologic cancers. Dr. Janice Rothschild is a board-certified general surgeon at Sturdy Health. She received her Doctor of Medicine from New York University and welcomed her residency in general surgery at New England Medical Center, where she was chief resident. Dr. Rothschild finds surgery to be the most satisfying specialty, as she can often diagnose the problem the patient has and have the means of curing it fully. Without further ado, please take it away, Dr. Latif.
Perfect. Thank you so much, Lindsay. I'm so glad to be here today with you and Dr. Rothschild to discuss an increasingly important topic in healthcare. A family history of breast cancer can impact one's own health in really significant ways. And we hope that with this discussion, we can help empower everyone in the audience to make positive changes to protect not only yourselves, but your loved ones also. This topic is so important because breast cancer is really prevalent in our world. After skin cancer, it's the most common cancer that occurs in American women. In this country, there are about 280,000 people with a new diagnosis of breast cancer every year. But it's important to remember that breast cancer is highly curable if known at an early stage. And that's why understanding one's own risk and focusing on early detection is so important. We know that 1 in 8 women will be diagnosed with breast cancer over their lifetimes. But it's really important to understand that men can also get breast cancer. So it's not a cancer that's specific only to the female sex. 1 in every 100 diagnoses of breast cancer occurs in a man. The main risk factors for breast cancer include female sex, older age, and of course, family history and genetic predisposition. And so that's really the portion that we're going to focus on today. So I will pass it on now to Dr. Rothschild to delve a little bit more into this.
Thank you. It's really a pleasure to be able to talk to you and answer your questions, maybe take some of the mystery out and try to encourage you about managing breast cancer if it should end up in your future. So the first thing I want to say is that the majority of breast cancers do not happen with a hereditary link. Most of them are what we call sporadic. They just happen. The same is true about risk factors. All the other risk factors, Dr. Latif mentioned a couple of them, but all the other risk factors, most women who get breast cancer don't have any particular risk factor. And I don't say that so that you should be fatalist or anything, but just so that you know that you, for the most part, generally, you're not doing anything that's causing breast cancer. The things you can do can help you find breast cancer and prevent breast cancer, but it's not anything that a person has to blame themselves for. But there are some cancers that are caused by an inherited gene, meaning that there might be something in your genetic makeup that puts you at higher risk for breast cancer. And as I said, very few of these are actually from clearly genetic. Only 5 to 10% of all breast cancers come with a genetic component. If you were to find, and we'll talk about how you can find and why you might consider testing, if you were to find that you have a mutation in your gene, it's not a sure thing that you're going to get breast cancer if you carry a genetic risk. It's not something that says you're definitely going to get or die from breast cancer. It just tells you that you are at higher risk, and in conversation, in discussion with your doctor, we can talk about what you might be able to do to decrease that risk. And it's something that we find very satisfying because it lets us focus on women who are at higher risk and what we can do about it. Next slide. So one thing to clarify, and it's kind of a subtle difference, you can have a family history even if you don't have a genetic mutation. Now, family history or a strong family history, and we'll talk about what that means, might clue you in to think about testing. But even if you were to find that you don't have a gene that identifies you at high risk, just having first-degree relatives that have breast cancer might put you at higher risk and put you in a position to be more cautious and careful about your screening. Now, first-degree relative means your mother or your sister. We do take into account other relatives. For instance, if you were to say that both my grandmothers and all my grandmother's sisters and my mother and all of her sisters, or maybe not my mother, but all of her sisters have, we'll take into account a pattern of family history of breast cancer. But you do have a twice risk, two times higher than your average, and we said that the average is 1 in 8, which is about 12%. So you're at a twofold risk if you have one first-degree relative, and a threefold risk if you have two first-degree relatives, so a mother and a sister, something like that. The other thing that we take into account is what the age of diagnosis of those relatives are. So a mother who developed breast cancer at 75 is a little bit different than a mother who developed breast cancer at 40. If you have a family history of breast cancer, and we'll discuss the other reasons why you might check, but you might have an inherited gene mutation, meaning your mother or your father, and it can be your father, has passed on a gene to you. Now, there are, over the years, we used to talk about BRCA. BRCA is a really famous and common one. But over the years, as our understanding of the human genome has gotten better, we've gotten better at testing for many, many, many more types of genes. So typically, when we do testing, we do what's called panel testing, meaning testing for all of these. And all of these genes have completely different situations in terms of your risk. Some might put you at twice the risk, some might put you at an 80% risk. They vary a lot. So just hearing that you have a genetic component doesn't necessarily mean that you're at high risk. And so what your risk would be would depend on your mutation, but it's also compounded by your family history. Awesome. Dr. Latif?
Yep, next slide, please. So thank you so much, Jan. I really want to speak a little bit to the question of the actual genetic mutations, which I think can be confusing to a lot of people. This question of who should consider genetic testing. The American College of Surgeons recommends that genetic testing be considered for every single person who's diagnosed with breast cancer. And this is a change from what we used to do in the past. In the past, it was really people who had breast cancer, we would look at the family history and see who might be at higher risk for having a genetic mutation. But we're really now opening this up and considering, or at least discussing it with every single person who has a new diagnosis of breast cancer themselves. Because not only can it affect future cancer risk and family cancer risk, but it can actually impact the treatment that we use for that current breast cancer itself. So that's a big group of people who we previously were not testing on a regular basis. Anybody who has either in themselves a personal or a family history of ovarian, pancreatic, prostate cancer, can consider genetic testing as well. And this is because some of the gene mutations we mentioned, that Dr. Rothschild mentioned, that can be passed down in the family, can be associated with groups of cancers that we worry about. So those are some of the cancers that we do pay attention to if they do run in the family. In terms of other considerations. Anybody who has a male relative with breast cancer should consider testing. Anybody who has multiple relatives with breast or other cancers on one side of the family, so a lot of people on their mom's side or a lot of people on their father's side, should talk with their provider about the option for genetic testing. And we also look at what kind of diagnoses people in the family have. So there is a subset of breast cancer that we refer to as triple negative type of breast cancer. And this helps providers like myself guide the treatment for the cancer. But these types of cancers are more likely to be associated with a genetic predisposition as well. So if there is a family history of family members who have triple negative type breast cancer, that's something that your provider should know. In terms of family heritage, we know that people who have Ashkenazi Jewish heritage with any personal or family history of breast or ovarian cancer should consider testing, because we see a high rate of certain types of mutations, including the BRCA mutation, in that group. And then, of course, if anyone has a family history of, family members who had cancer at a very young age, multiple cancers in the same family member, or if someone in their family is known to have a genetic mutation that could impact cancer risk, then they should talk with their provider to consider genetic testing as well. Next slide, please. So what exactly is the genetic testing process? If you think that genetic testing may be something that's right for you, the most important step is really to talk to your primary care provider. They'll speak with you to see if this makes sense, if it's appropriate. And if so, most likely they'll refer you to someone who specializes in this. So that might be a genetic counselor or another experienced healthcare practitioner. So for example, a lot of people in the oncology world also are comfortable with genetic testing. And there are other providers as well who do this a lot, and they may be comfortable seeing people in this circumstance. There are benefits and risks to testing. And so that's why it's so important to talk with somebody who can, go through this. So for example, the benefits can include improvements in managing a known cancer, as I alluded to, or early detection or even prevention of a future cancer. The main risks tend to be more financial in nature. For example, if health insurance doesn't cover the cost of the test, or if someone is found to have a genetic change that goes into your medical record and essentially becomes like a pre-existing condition. And so if that person was to then go on to apply for life insurance or disability policy, it can sometimes affect the premium. In general, that information is so useful. The benefit typically outweighs the risk, but especially for young people who are considering genetic testing, we always like to make sure that they understand that potential ramification. There are governmental protections in place. So, for example, employers cannot discriminate against anybody based on their genetics. It's also important to recognize, though, that there are emotional impact that these results can take. So if someone was found to have a specific gene mutation that impacts their cancer risk, that can really affect that person emotionally. So you have to be prepared for those potential results. And that's why it's so important to have this sort of a discussion with somebody before embarking on genetic testing. And then, I also want to mention that there's always a limit to what we can learn with genetic testing as well. Dr. Rothschild spoke to the fact that there can be people who have a strong family history of various types of cancer, or even one particular type like breast cancer. And if we do the genetic testing, we don't find a single mutation that explains it. And so there are some limits to what we know and what we understand still. So if you meet with your provider and they do refer you on to somebody who's experienced in genetic testing, you would meet with that practitioner. They would go over your family and personal history. And if ultimately it made sense to proceed with testing, then they would take a sample, blood or saliva sample, and we usually send it to a reputable lab where they are now doing primarily these panel test. So we're checking for a broad number of mutations that can impact healthcare, that person's health. We typically get those results within 2 to 3 weeks, and generally prefer that someone come back in person to review those results, just because it can be a nuanced conversation. Those results would basically tell us, if there is a gene mutation. So that would be considered a positive result in medicine, that there is a gene mutation that can impact cancer risk. And then guidance would be given based on what to do based on that cancer risk. A negative result would indicate that there's no mutation that was found. But then there is a third potential, which is called a variant of uncertain significance. And this is that gray zone. So sometimes we see a change in a gene that is not known to be beneficial. It's not known to be harmful. It's just a change that is found when that testing is done. And that's called a variant of uncertain significance. Right now, we don't change our management in any way of that person. It's not considered to be something that's, going to harm them in any way. But over the years, we'll learn more and more about those gene changes. And oftentimes the labs will then be able to reclassify that as either a positive result, meaning that there could be some implication, or a negative result, meaning you don't have to worry about it. So I'll pass it back now to Dr. Rothschild, and she's going to speak to what can be done if there is a concern regarding an increased risk for breast cancer based on family history or genetics. You can go to the next slide. Thanks.
So we're going to focus on strategies for high risk of breast cancer, but I do want to just reiterate what Dr. Latif mentions, which is that some of these genes do implicate other diseases besides just breast cancer. You might have a gene that says that you're at higher risk for breast cancer, but also perhaps a higher risk for colon cancer and a higher risk for prostate in men. So that's why it's very helpful after these testing to meet with a genetic counselor, geneticist, to actually talk about the scope of what the risk is and what you can do about it. And many of these things can be handled with a lot of the screening tests that we ordinarily recommend. So if you're found to have, let's call it a variation in your gene that we know can cause breast cancer, as I mentioned, that can be anything from a 2 times risk for breast cancer to maybe a 5 to 8 times risk of breast cancer. And it will vary with the gene, and it will also vary with your particular genetic makeup. So you'll never see somebody who treats breast cancer who's not going to say, make sure you get your mammograms on an annual basis. Now, there's a lot of discussion about what annual means. For the most part, those of us who treat breast cancer say annual after 40, but there is a lot of conversation every other year between 40 and 50, when you should stop at age 70 or 80, depends, and that's a conversation to have with your doctor. But if you have a family history of somebody with breast cancer, say at 45, then we typically recommend starting your screening 10 years before that. The same is actually true with colon cancer, because we know that there can be little tiny changes that can eventually show up as breast cancer at 45, but they may have been identifiable at 35, and they could be either treated early or prevent the development of breast cancer. So 10 years before the person in your family who's had breast cancer, and be careful about doing annual mammograms. Now, mammograms, of course, have limitations. They don't find all cancers. So there are other things that you can do, and typically this is geared towards women who are defined as high risk. And there are other X-ray tests, radiology tests that you can do that are good for high-risk patients. Now, just if you get into this route, you will find that there's a distinct definition about what high risk. We talked about 12%, which is 1 in 8. Typically, we don't start thinking about high risk until you get about a 20% chance of a 20% lifetime chance of developing breast cancer. And I say we don't talk about it, but really your insurance companies don't talk about it, and they won't approve supplemental screening until you get to that point of 20%. If you wanted to do more testing, then you could do either an MRI or an ultrasound. And an MRI is much more sensitive than mammogram, which is good and bad. It's more sensitive and it will find things earlier, and it's bad because it's so sensitive, it will find not only the thing you're looking for, but a little spot here and a little spot there, and then you'll end up with ultrasounds and biopsies for things that ultimately turn out to be nothing. So that's a conversation to have. If you decided to have supplementary screening with an MRI or an ultrasound, the way we usually do it is to get your mammogram, annual mammograms. 6 months later, you get this other test. And then 6 months after that, you get your mammogram. So each test is yearly, but you get twice as much testing. And that's what makes it extra testing for people who are at high risk. I usually tell women to get twice yearly breast exams. If you see your PCP, your gynecologist, that's sufficient for twice yearly examinations. There's always conversation about breast self-examination. Nobody's ever proven that breast self-examination is going to save your life, but I do find that women who are familiar with what their breasts feel like can appreciate a difference. If you are familiar, perhaps on a monthly or every other monthly basis of checking your breast, if there's a difference there, you'll probably recognize it. If it persists, then you'll know that you want to have it checked out and just to go get an examination by your PCP or one of the high-risk clinics, and we can talk about that. Those things will find breast cancer. They won't prevent breast cancer. They will help you find breast cancer early, but it doesn't do anything to your ultimate risk of developing breast cancer. Some lifestyle changes that you can make to prevent breast cancer. There are not many lifestyle things that you can control. One thing that you can do is control is obesity. Obesity control and exercise can have an impact on your risk for breast cancer. Alcohol can have a risk impact. And there is medication to help reduce risk. And so when we see somebody who's at a particularly high risk, you can arrange to talk to Dr. Latif about some of this medication. It happens to be a medication that we give to women with breast cancer. And we've discovered kind of by the way, it also helps prevent breast cancer. Of course it has risks, of course it has side effects. And so you have to decide whether your risk is worth it to you to try to decrease it. But it is, we'll say, a great drug because it will cut your risk in half. So you could come down to actually kind of a normal risk profile by taking the medication. More definitive, let's say, but of course more invasive and drastic is what we call risk-reducing surgery, and that means bilateral mastectomies. The best way to prevent breast cancer is with bilateral mastectomies. There's no question about that, but obviously the impact is tremendous. One thing that you have to remember is that it does not decrease your risk to zero. There's just no way that I or any other surgeon can get rid of every breast cell to make you come down to zero. In multiple studies, there's about a 3% chance that you might get breast cancer even after bilateral mastectomies. But 97% risk reduction is as good as we can get. And of course, that can be done with reconstruction at the same time. And in order to coordinate all of this, right? You can be seen and followed in a high-risk clinic with providers that are familiar with all of these options and can help you talk through and decide about what to do. Excellent.
All right, thanks, Jan. Jan spoke to the person who is at higher risk for breast cancer and things that we can do based on that information. But as I mentioned, it's also really important for people who do have a diagnosis of breast cancer to understand their genetics, because there can be implications in the actual treatment of their cancer based on their genetic history. And that's the reason that we now recommend considering testing for all of these patients. So if someone is found, for example, to have a genetic change that significantly increases, that was not only associated with their current breast cancer, but significantly increases the risk of even a future breast cancer, then when they speak with their surgeon, such as Dr. Rothschild, they may choose to actually undergo a bigger surgery, such as the bilateral mastectomy or having both breasts removed, instead of the smaller surgery needed to just to treat that specific current cancer. So that would be considered a preventive surgery. And that genetic information can help guide that person as to whether that makes sense for them. Additionally, women who are found to have genetic changes that can be associated with an increased ovarian cancer risk. So this might be, for example, a BRCA mutation, may choose to have their ovaries and fallopian tubes removed as well, either in the same or a separate surgery. But this kind of comes to light at the time of their breast cancer diagnosis. Some genetic changes can actually impact the safety of receiving radiation after a breast cancer diagnosis. So we know that people with certain gene mutations can have more harm related to radiation than benefit. And so for those patients, we really find it useful to know that information in advance. They make their surgical decisions based on the knowledge that radiation may not be a good step for them. And then in terms of what I do, which is focusing on the medication aspect of breast cancer treatment, absolutely makes a difference. So we know that some people benefit from receiving, for example, chemotherapy before surgery or after surgery. And if there are certain genetic changes present, it might change which medications I choose to give them as part of their chemotherapy regimen, because we know that some people with genetic changes have better results with certain medications than others. Additionally, there's a class of medications called PARP inhibitors, which are oral pills. And there are certain genetic changes that people can have that we've learned actually that those people do really well with those oral pills. And so oftentimes after surgery or even in more advanced cancer situations, we might put somebody on that medication as well. And so that's why it's so helpful to have that information as we navigate the whole treatment process. And then even after we complete breast cancer therapy, we know that we have to watch over our patient, watch over that person to help keep them healthy. And so these mutations can impact how we move forward and how we monitor that person going forward. Dr. Rothschild spoke to not only mammograms, but potential MRIs and kind of closer or more frequent monitoring. And that might be something we discuss as part of, what we refer to as our surveillance strategy. So I'll pass it back now to Dr. Rothschild so she can put this all together for us.
So as I alluded to before, the point of this talk is not to scare you, and the point of finding out that you have genetics or genetic abnormality is not to scare you, but to empower you to know that this is something that you can address, and there are ways to address it, and we've touched on a bunch of them. Your healthcare provider can try to determine your breast cancer risk. It can take into account not only your family history, but there are models that we use that take into account things like your ethnic heritage, like as we mentioned, the Ashkenazi Jewish. Takes into account how many children you've had, whether you've had breast biopsies in the past, what the breast biopsies have shown. And then it's put into a computer and comes up with a risk profile for a 5-year and lifetime risk for breast cancer. And as I mentioned, we don't usually talk about intervention until you get to about 20%. If there are signs that there could be something in your family, then talking to a geneticist or talking to find out whether genetic testing is good for you, and could be reassuring, could be at least an indication that you need to take one of these steps. And if you are found to be at high risk for breast cancer, you certainly can either talk to Dr. Latif or myself, or be referred to a high-risk clinic to discuss all of these options about which one suits your profile for your comfort and managing your risk. And if you are found to have a genetic mutation, then you should talk to your family as well, because they could potentially be at risk too and might need to be tested as well. Next slide. We'd love to answer any questions. I hope we've kind of stirred up a couple of curiosities and questions, and we'd be happy to answer about this or anything else that you have.
Thank you, Dr. Latif and Dr. Rothschild. We're going to jump into the question and answer section of the webinar, and we did receive a few questions. The first question is for Dr. Latif. What types of lifestyle changes can help reduce risk in high-risk individuals, and how effective are these lifestyle changes when it comes to breast cancer diagnoses?
Okay, that's a great question. I know Dr. Rothschild alluded to some of these as well. You know, as she said, there's a lot of a lot of risk factors we can't change. So we can't change our genetics and family history. We can't change when we had our first period or our last period, things like, of gynecologic risk factors, things like that. But weight and obesity is a big one. We know that our fat cells actually create estrogen. And so that when people have more fat cells, there's more estrogen in the body, and that can often stimulate and encourage breast cancer, a specific type of breast cancer. So reducing the weight to a normal range has a significant impact in reducing the risk of breast cancer. Avoiding alcohol or minimizing it can help as well. So keeping alcohol to 2 or fewer drinks per week has been found to be associated with a lower risk of breast cancer, and avoiding tobacco. And then, the other thing I'll mention is our diet. So studies to look at diet and cancer are very, they're difficult studies to do, and it's hard to kind of put numbers to it. But we do think that a Mediterranean type diet that focuses less on red meat, saturated fats, and really more on whole foods, fruits, vegetables, olive oil, fish, tends to have a lower risk of cancer associated with it. And then one of the biggest lifestyle changes that we know has an impact in how people do is exercise. And this impacts not only women who are at higher risk for breast cancer and reducing their risk, but also even people who have breast cancer. It helps to reduce the risk of that cancer coming back. At least 150 minutes of exercise per week, including some strength-based exercising, has been associated with a reduction in cancer risk. In terms of the question about how much does this make an impact, it's really hard. It's been hard for scientists and physicians to really assign statistics to exactly how much of a reduction there will be. But we know that people who practice all of these lifestyle changes can certainly reduce not only their cancer risk, but also generally achieve a better wellness. And so even if they still end up being diagnosed with something in the future, which is absolutely still possible, they're going to be in a better position. They're going to be healthier to be able to fight it. So I do think that's a really important consideration. Hopefully that answers the question.
Thank you, Dr. Latif. The next question is for Dr. Rothschild. Can you share a little bit more about what risk-reducing surgery looks like? How long is the recovery period? Does it require regular screening and check-ins?
So what we call risk-reducing surgery is removing both breasts. Removing one breast really doesn't decrease your risk to any significant amount. So you're talking about removing both breasts. And as I said, you can have reconstruction at the same time. Now, the way we do the mastectomy, you should not need X-ray screening. You shouldn't need mammograms. Obviously, you're going to be in follow-up for whatever other risk your gene form causes, but you don't need to have mammograms. The recovery actually depends primarily on which reconstruction you choose, and just perhaps briefly. So when you do surgery, you have a choice of using an implant, which is a little ball of fluid, or using your own tissue. You can use tissue from your stomach, you can use tissue from your back. When you use an implant, it looks great. It looks good in a bikini. It looks really nice. It doesn't feel completely natural, but one of the advantages is it also doesn't age naturally. It just kind of always stays young. But it doesn't feel completely natural. If you use your own tissue, it feels a bit more natural. But you have to remember that you're recovering from 2 surgeries, from giving the tissue and from putting the tissue. So the recovery from using what we call tissue-based, using your muscle or your skin, is much greater. So I would say an implant-based mastectomy and reconstruction would be about a 2-month, maybe a little bit more recovery. If you use a muscle-based, it's probably closer to 3 months until you're really feeling yourself. One other thing that we can talk about used to be when we did a mastectomy, we always took the nipple and the areola. We used to feel that leaving that leaves too much breast tissue and that the risk is too high. But then as we've tried to push the envelope a little bit, we have found a way to keep the nipple and the areola during the surgery. So you can have a reconstruction keeping all of your skin and all of your nipple. Now, the thing to remember is that in order to do that safely, we have to remove all the tissue out from underneath the areola, which means all the nerves and all the blood vessels. So the nipple isn't going to have any sensation. It's just going to be a cosmetic appearance of the nipple. So that's usually typically risk-reducing surgery. Often is, if there's no question of cancer in there, it's usually a nipple sparing, skin sparing, meaning you leave all your skin and all your nipple. You usually can put the incision underneath the crease of your breast, and so that barely shows as well, and then do reconstruction at the same time with either implant or your own tissue.
Thank you, Dr. Rothschild. We have quite a few more questions, so we'll move to the next one if you were all set. What are your thoughts on using tamoxifen prophylactically in people who have been identified as high risk?
I can answer that. So it really depends on what the reason for being high risk is. Sometimes that risk is based on genetics, and if if we know that there's a significantly higher risk, Dr. Rothschild alluded to some gene mutations giving a 60 or 80% lifetime risk of breast cancer. And if you are uncomfortable with having a preventive surgery, then it certainly is reasonable to consider using an anti-estrogen or medication or an estrogen blocker to cut your risk. And some studies have shown that risk can get cut in half taking those pills once a day for 5 years. That still has to be part of a very close monitoring strategy. That still includes clinical breast exams a couple times a year, and mammograms and MRI imaging to really be on top of if there is a change that should develop. And this choice of medication, whether it's tamoxifen or some other anti-estrogen medications that the brand names are Femara, Arimidex, or exemestane. If those are considered, really the choice of which one to use is usually guided by either a medical oncologist like me or somebody who's in a high-risk clinic where they're really experienced in taking care of women who are in that same position. So that is absolutely an option in that setting. There are other reasons that people can be at high risk for a future breast cancer aside from their genetics. Sometimes Dr. Rothschild sees people who have a biopsy that's a little bit abnormal and they have surgery and they didn't have cancer, but they had something we refer to as atypia. So kind of atypical or not typical cells in the breast. They're not cancerous cells, but it just tells us that there's something, active in that breast tissue, and that person is going to be at a higher risk for breast cancer in the future. So I absolutely am happy to see those patients as well, because it is relevant to have a conversation about whether to consider taking a medication in addition to close monitoring. What I will say is that with these medications in general, when we've used them for people who have pre-invasive breast cancer, so something referred to as DCIS, or stage 0 breast cancer. When we've used these anti-estrogen-based medications, we have absolutely reduced the risk of that person developing a future breast cancer. We've cut it in half, but we've never proven that that person lives longer because of those medications. And that's probably a testament to how well people do in terms of staying connected with their providers, getting their breast imaging done, bringing any changes, to the attention of their provider. And so even if they still go on to develop a breast cancer, it's usually caught early. And as I mentioned, when we catch breast cancer early, it's much more likely to cure it. So there are risks and benefits of these medications. And I think it really requires like a very personal conversation with your provider to figure out if it makes sense. Hope that helps.
Thank you. Our next question. I was told years ago that I had a gene mutation called the MTHFR and was prescribed non-folate B vitamins. Is this the genetic mutation you're referring to or another?
Hold on. I was making sure I was not muted. That would be kind of like a discussion, a discussion to delve more into that person's history. But there are a lot of mutations we find when we do this panel testing. And some of those gene mutations are absolutely associated with increased cancer risk. And then some of those mutations are changes that we learning more about still, and are not necessarily increasing someone's individual risk by itself. Sometimes it's only if they have two abnormal copies of a particular gene that we worry, or it's sometimes an abnormal copy that we originally thought was associated with cancer, but maybe is less likely so now. I hope I understood the question correctly, but I'll just say that the panel testing we do is primarily looking at the genes that affect specific cancer risk. Specifically like the MTHFR mutation, sometimes those sorts of mutations are tested when someone has other issues like blood clots, for example. And so that type of genetic testing is often based on like a specific medical issue, and a specific gene is tested in that circumstance. So it really needs to be put into context, with your provider.
Thank you. Our next question. I am 62. My mother in her 70s and her mother in her 60s died of breast cancer. I get a mammogram / MRI alternating every 6 months. Does genetic testing make sense?
So it was the person who's asking the question, and then their mother and their maternal grandmother?
It says mother and let's see, my mother and her mother, so grandmother, yes, died of breast cancer. They were in their 60s and 70s.
Yeah. So first of all, I'm so sorry to hear that you had to see your loved ones go through that. I think there's clearly a strong family history, because you have that first degree relative and then your maternal grandmother as well. So multiple people on the same side of the family. And I think paying attention to that and kind of being monitored closely with the imaging studies that you indicated is absolutely the right thing to do. In terms of the genetic testing, I think it's certainly reasonable to warrant a deeper conversation. I think Dr. Rothschild mentioned that with a family history, the age at which someone develops a breast cancer is really relevant. We know that breast cancer is more common after the age of 50 when someone goes through menopause. And so the fact that your mother and your grandmother developed breast cancer, after menopause makes it a little bit less likely that it's associated with a single gene mutation. But that being said, sometimes until we really think about it, we don't realize or remember all the other people in the family who could also have had other types of cancer. Maybe not just breast. Maybe there was somebody with ovarian or uterus or colon or prostate or pancreatic or melanoma or all the different types. And so I do think it makes sense to just, when the next time you see your primary, just kind of make sure you have a good understanding of all the rest of your family history. And if there is a pattern, it's certainly reasonable to ask if it makes sense for you. And Dr. Rothschild, if you have anything to add, feel free.
Okay, our next question. I have a CHEK2 mutation and currently do my mammogram and then MRI 6 months later. I read last year that the MRI may no longer be needed due to the low, although still elevated risk. Do you have additional info on the elimination of the MRI for that specific mutation?
Sorry, it just cut out for me a little bit. Can you just say the mutation again? Was it CHEK2?
CHEK2, correct.
Yeah. So CHEK2 mutations are refer to these days at kind of like a moderate increased risk. I think that the specific scenario really depends on not only the genetic change and, how many genes were abnormal. Was it one or two? Most people, it would just be one, either from their mom or their father, but also what the family history is. So if there is a CHEK2 mutation that somebody has and they have a very strong family history of breast cancer, then even if we say that that person's risk related to that CHEK2 mutation is not as high as maybe some other gene mutations, because the family history is strong, I would still advocate for, a more assertive approach in terms of closer monitoring and sometimes even consideration for preventive, medications or surgery. In the same way, sometimes we have patients who have a mutation that we do worry about, even on a higher level, that is associated with a very high risk of breast cancer, but they have no family history. And they know their family, so it's not that they just are not aware. And so it is interesting that these gene mutations kind of penetrate in different people in different ways. And that's one reason that Dr. Rothschild mentioned that just because someone has a mutation, it doesn't mean you're going to get that cancer. It's just that we have to pay attention to understand better what that risk for that person is. So specifically for you, I think if, you were doing mammograms and MRIs, then ultimately someone, told you that maybe you don't need the MRI, I think it's definitely reasonable to explore it further and just find out, well, what's the rationale for that in your particular story and in your particular family situation. Some people do this extra imaging and there are false positives. And so sometimes, that can also implicate whether somebody wants to continue or not. But I will say that I think the family history will make a big difference in terms of that decision.
Thank you. The next question, if you have been tested at the beginning of your diagnosis and the result was negative, should you be genetically tested again after a few years to look for any changes?
Good question. So in terms of most of the panels that we're using for genetic testing that are testing like 40 plus genes, certainly in the last few years, there have not been any specific additions that of genes that impact breast cancer risk. So it really depends on how much time has passed and what your family history is and what kind of cancer you had and when you were diagnosed. Sometimes if I meet somebody who had breast cancer at a very young age and was tested 10 years ago or 15 years ago, and maybe only had a few genes tested at that time, I absolutely do think it's appropriate. And I've had actually many patients that Dr. Rothschild has referred over in those circumstances to get updated genetic testing because we have a lot more information now than we did then. But if only a couple of years have passed since you had like a multi-gene panel done, I think it's usually not necessary to retest that quickly. It's really, it would be something to talk to your oncologist or your provider about. But usually if it's just a few years that passed and it's been recent testing, I wouldn't worry too much. And Dr. Rothschild, you're on mute.
Sometimes the companies will save the samples, and so you don't have to be tested again, but they can rerun the sample for any new technology that's developed.
Looks like we have 2 more questions to go. If you have any additional questions, please put them in the chat now. We do have only about 7 minutes left of our talk, so we're hoping to answer everything you have today. So the next question, will Sturdy be offering enhanced mammograms with contrast? My breast cancer may be difficult to see because it doesn't form a lump.
Yeah, I can speak to that. So there is the advent of mammograms with IV contrast, and the idea that these can sometimes replace some of the other supplemental imaging that's being considered. It does seem like it gives a better picture. Right now, this has been something that's been discussed here. Right now, there's no active plan to start that. There's a lot of reasons for that because so right now our mammogram imaging is with tomosynthesis. So they do the 3D mammograms here and they do give a really good picture. And we do have the ability to do the supplemental imaging Contrast is okay for some people. Some people have allergies to contrast. Contrast can impact kidney function, and it, you know, can sometimes have some risks depending on what medication somebody's on, if they have diabetes. And so for that reason, we're not starting it right now here. It's definitely not considered standard of care, but I think in the future that might change depending on, you know, how, you know, further conversations and further research on it. Dr. Rothschild, are you aware of anything else on that topic?
There actually are a lot of modalities being investigated. Intravenous mammograms, contrast mammograms is one of them. But as Dr. Latif said, it's not yet standard of care. And generally speaking, most of your insurance carriers won't be paying for it because there are variable technologies that are being tested, and none has really been shown to have a large impact. They may be more sensitive, but kind of like the tamoxifen or the MRI, they may show you something, but it won't have an impact on your long-term outcome. So they haven't become standard yet. But the tomosynthesis, the 3D mammograms, are offered here and are an advantage to the 2D.
Okay, so we have one last question. My husband, this is for Dr. Latif, sorry. My husband and I are planning to start a family this year, and my mother-in-law sadly passed away from breast cancer. Should we opt for genetic testing, and will our child be considered high risk for breast cancer?
Oh, well, first off, I'm sorry to hear about your mother-in-law's passing. You know, that's such a important conversation to have because anytime you're thinking about getting pregnant, you want the best for your child, of course. You know, when you go to meet with your OBGYN, especially if you're meeting with somebody before trying to conceive, then they will take a family history. You know, if it is one person in his family who had breast cancer, especially after, you know, the age of menopause, then most likely it would not typically warrant specific genetic testing. But that being said, you know, there can be a lot of information that an OBGYN can glean if they're discussing directly with you and your partner. And so if they ultimately feel like there could be something running in the family, whether it's cancer risk or other illnesses, then oftentimes the first step is would be to test your partner, to test your husband, to see if he carries that, and then there could be you know, a discussion about how that could impact your you know, your child. You know, I will speak to you know, the topic of for example, women who have breast cancer who do have a genetic change and they're being treated, and they might have young children, and how that affects their kids. You know, in general, for, you know, young children, we don't advocate testing, doing genetic testing. We just advocate that, you know, their pediatrician should be notified of that, you know, child's family history, the genetic history, so that they can be guided as they grow up and as they enter adulthood as to, you know, what should be considered. But any prenatal testing would really depend on like the strength of the family history, and typically one person, you know, one person in the family with cancer probably would not justify doing an extensive search.
But I hope we've also relayed the message that finding out that you have a genetic mutation is not necessarily a terrible, horrible thing. That what we're trying to tell you is that it's a good piece of information to help take care of your health and to help you screen and find things early, not necessarily to just be just completely fearful of.
Yeah, that's a great point, because, you know, sometimes people ask me, well, what's the reason for me to get tested? I already know I have cancer. And I think really empowering yourself with more information to keep yourself healthy going forward, even if you've already been diagnosed, and moreover to help protect your family, I think that can be really empowering as well. So, you know, I think it can allow us to make sure you're as healthy as possible going forward, for sure.
Great. Thank you both so much for this wonderful conversation. That was our last question. So I want to thank each of you for joining us today during Breast Cancer Awareness Month. We hope that this information was helpful for everyone. If there's one takeaway, it is please get your mammogram. Mammograms matter, and as you heard from our panel today, early prevention saves lives. Sturdy Health does have imaging services available. If you're interested in scheduling an appointment for a mammogram, please contact our imaging department. That phone number is, if you have paper, 508-236-7770. If you have any questions after this, if anything comes up, please contact our panel. Their email addresses are available on the screen. And thank you again for joining us.
Thank you, everybody. It's a pleasure.